All right, welcome everyone. We're going to jump right into a topic that is absolutely critical for every single one of us in the pharmacy, counseling on potassium disturbances. We're going to break down exactly how to manage and advise your patients on this vital electrolyte to keep them safe. So picture this, a patient comes in with a new script. Simple enough, right? But what if that one change could send their potassium levels into a danger zone? What do you say? This is where we come in, because our intervention at the counter is so much more than a check. It's a crucial safety net. Okay, let's get back to basics for just a second. We all know potassium is the body's major intracellular cation, but what does that really mean for our patients? Well, it's basically the spark plug for our nerves and muscles, especially the heart. And our number one job is to help our patients stay in that super tight Goldilocks zone, 3.5 to 5. So what happens when things go wrong? Well, if those levels dip below 3.5, we're talking hypokalemia. If they shoot above 5, it's hyperkalemia. And here's the tricky part you've got to watch out for. See how muscle weakness shows up on both sides? That's exactly why you can't just go by symptoms. Lab work is absolutely essential. But here's the bottom line. The number one reason we care so much about this, whether it's too high or too low, the biggest risk is the same: potentially fatal cardiac arrhythmias. It can literally stop the heart. That's why our role in counseling isn't just helpful, it's truly life-saving. All right, let's break this down. We'll start with the too high scenario. Let's talk about taming hyperkalemia, looking at what causes it and what to do about it. Okay, so who are the usual suspects? This table lays them all out. You're seeing these drugs every single day, right? Lisinopril, losartan, spironolactone. The thing to really hammer home with patients is that these effects can stack up. An ACE inhibitor plus a potassium-sparing diuretic, that's a huge red flag you need to catch. Now, if things get really bad and a patient lands in the hospital, there's a clear three-step playbook for managing an emergency. It's not just about getting the number down, it's a race against time to protect the patient from the most dangerous effects. Step 1, and this is non-negotiable, is to stabilize the heart. We do that with IV calcium. And let's be super clear, calcium does not lower the potassium level one bit. What it does is act like a shield for the heart muscle, protecting it from those high potassium levels. And wow, is it fast. We're talking an onset of just 1 to 3 minutes. Okay, so once the heart is shielded, now we work on actually lowering the potassium in the blood. Our most powerful tool for this is insulin. Think of it like a key that unlocks the cells and forces potassium to move from the plasma back inside. And the effect is pretty dramatic. You can expect a drop of 1 to 1.5 millimoles per liter within the first hour. All right, we've covered too high. Now let's flip the script and look at the other side of the coin, which, let's be honest, we probably see even more often in community practice: hypokalemia, or low potassium. And here are the drugs that are notorious for kicking potassium out of the body. Furosemide, HCTZ. I mean, how many of those did you dispense just today? These are the big ones. Anytime you see a new script for one of these, that should be your trigger to have a conversation about the signs of low potassium. So, how do we fix it? The route we choose is a big deal. For most of your patients, the go-to is going to be oral potassium chloride. It's safe, it's effective. IV is really only for those scary, urgent situations. Think active arrhythmias or someone who physically can't take anything by mouth. Now, this is a fantastic point that sometimes gets overlooked. It's not just about replacing potassium. You have to pick the right salt. Yeah, KCl is our workhorse for sure, but what if your patient also has metabolic acidosis? Potassium citrate is a much better choice. Or if they're low on phosphate too, you've got to use potassium phosphate. It's all about treating the whole clinical picture. Okay, so we've got the background science down. Now for the most important part. Let's put this into practice. This is your patient counseling playbook, the stuff you can start using at the counter today. So you're handing over a new prescription for lisinopril. What do you say? First, ask about salt substitutes. So many people don't realize they're packed with potassium chloride. Remind them why they need those follow-up blood tests. Talk about high potassium foods, not to avoid them completely, but just to be mindful. And of course, tell them what to watch for, that telltale weakness or numbness. And when you have those really high-risk combos, like an ACE inhibitor with spironolactone, this monitoring schedule is absolutely crucial. You need to stress this to the patient. It is so important that you get your blood checked at 3 days, 7 days, and again at 4 weeks. It's non-negotiable for their safety. Okay, now for counseling on the supplements themselves. These tips are gold. Always, always tell them to take it with a full glass of water and some food. It can be really rough on the stomach otherwise. And please explain the ghost tablet. You will save yourself and the patient so much panic when they see that wax matrix in their stool. And here's a pro tip. Always think about magnesium. If their magnesium is low, you can give them all the potassium in the world and their body just won't be able to hold on to it. And if you remember one single thing from this entire explainer, let it be this. Do not let a patient take potassium supplements and a potassium-sparing diuretic at the same time without very, very close monitoring. It is a classic recipe for disaster. The risk of severe hyperkalemia is just way too high. Finally, keep these patient groups on your high alert radar. Anyone with kidney issues, older adults, people with heart failure or diabetes, their bodies just don't have the same ability to handle potassium shifts. You need to be extra, extra vigilant with them. Look, what we do really matters. Being proactive with this kind of counseling can literally save a life. So my question to you is this. Think about your patient list for today. Who on that list needs a potassium review?